Okay, so good afternoon, everybody. I'm Dr. SWATI Agarwal, and I'm going to discuss today on the preoperative and the intraoperative digital and ink marking techniques for toric IOL implantation. Well, for any toric IOL to give results with accuracy and precision, the reference markings should be spot on. The reference markings could be slit lamp assisted, bubble marking, freehand, the digital marking, femtolaser assisted, or straightaway the intraoperative aberometry. Well, coming to the slit lamp markings, the patient is sitting upright and a fixed point straight is, and looking at a fixed straight point, and a thin coaxial beam is then turned to 180 degree, and on a dry cornea we can mark either with a pen or a 26 gauge needle. Well, I personally do not like marking with a 26 gauge needle because it scratches the cornea on the day of the surgery. And if you have multiple cases, then you need to rely on your technician to mark it with a pen, because then the movement of the patient becomes a problem. Well, the next technique would be the bubble marking technique. Well, here the 3 foot points are marked with ink, and then after a speculum has been put, the bubble is kept in the center of the lines, and then we gently press it on the corneal limbus, like we can see here. But then again, what the patient feels, it can somehow be a little cumbersome and something blocking the front of the eye. Coming to the freehand technique, well, on a dry cornea, the patient has to look straight and we mark. The tip here is marked with the tip of the pen. Do not use the side edges, because then we get a thick mark. So what we need is a thin mark, and mark only once. So how do we confirm whether this reference marking is at the axis of 180 degree? Well, this can be confirmed by various smartphone apps available online free on the iOS platform. We have the ToriCam by Dr. Graham Barrett, none other than him. And on the Android platform, we have various such apps like the iToric we shall be discussing here. Well, the iToric app, so we just need to download it from the Play Store, and we open the app, and this is a gyroscopic assisted app. So when we're turning the camera right or left, the axis stays at 180 degree. It's not turning. So what we need to do is just switch on the light on the camera itself. Now gross alignment of the circle is done. Keep the mobile rotation at 0 degree. Align the corneal reflex at the center of the eye. Take the photograph, manually adjust the cornea with the circle, manually align the cornea with the circle now, and press on the protractor sign at the bottom. So this gives us a red line. Now drag one point of the mark through the ink mark and the other through the center of the circle. Now we get the misalignment at the top. So another tip here would be to pass the red line through the ink mark at the limbus, because the ink mark could be tilted. So if we are doing it post limbus, then we are not getting the correct marks. So just take out the ink mark off the limbus. We need to mark it there. So this patient is now shifted to the OT, and on the OT we held the Mendes ring in the left hand and the axis mark on the right hand for a right-handed person, and marking of the steep meridian is done, and the 90 degree axis, if you're operating at the 90 degree axis, mark only once. But again, the fallacy here is that it could be there could be double marks, there could be smudging of marks or fading away of the marks. So we have the image guided systems to overcome it. So this image guided systems with no financial interest, well, I'm displaying here the Varian measurement unit with the near infrared LED lights. It measures the sphere and the cylinder power and the axis of the central 2.8 degree millimeter of the cornea, and uses multiple reference points on the conjunctiva, the limbus, such as the scleral vessels, limbal vessels, and the iris features, to create a digital overlay between the live surgery image and the images taken preoperatively. So these points are passed on to the vision planner and then to the Varian digital marker. Like here in the OT, we can see that we get all the marks, the incision marks and the primary axis, everything. So how do we proceed with it? I've put my incision at 90 degree, and you always follow one particular axis for your toric IOLs. If you're operating temporally, always go for 180 degree, or always go for 90 degree if you're operating superiorly. It also gives us, the Varian digital marker, the rexis markings, so that there's a continuous overlap it helps us in a continuous overlap of the optic of the IOL. And what we need to do is just proceed with the normal surgery. And after the phacoemulsification has been done, we just need to implant the IOL as smooth as it is without worrying about the orientation of the chart and which axis to give. It just makes the mind of the person, the mind of the surgeon very calm and peaceful. So over here it's marked at a 2 degree. We also need to wash behind the IOL so that their post-op rotation is limited, and this is how it is done. So comparing, there have been various studies which tell us that the digital image guided delivers better outcomes than the slit lamp assisted in the conventional manual ink marking techniques in terms of astigmatism. Well, over here I would just like to mention to all of you that whatever works in best in the hands of surgeon, please go for it. You do not have to go for all sophisticated instruments to start your toric, but yes, once you've built up your practice, you can always go for whatever fancy instruments you want. But initially, please do go for any of the techniques which works best in your hands. Like over here, we had the left hand image is of the smartphone assisted, and the right image is the image guided. So the smartphone is showing a mark rotation of 4 degree. Now when we put the same patient on the digital overlay, that is again showing a rotation of 4 degree. We've also done a study on this, and we found very good results have been published elsewhere. So now coming to the femtosecond laser markings. So this can be corneal marks. The femto laser can give us capsulotomy marks. Well, though the capsulotomy marks are supposed to be more reproducible, sharper, radially closer to the IOL plane, I personally prefer the corneal marks because I don't like marking the capsule. So this was a patient. The phaco-fragmentation with the femto laser has been done, and the femtorexis has been done. So I'm also marking with the ink. So after the Mendes ring has been applied, we can see that below the rings there is a faint axis mark which has been done intracorneally by the femto laser. So it is very accurate as far as my experience is concerned in all the femtotoric cases I have done till date. So, another advantage of this is that this marks not just guides us intraoperatively, but also post-operative alignment it shows us. The post-operatively we can very easily see that it is aligned. So again, another technique is the intraoperative aberometry. Well, it gives us real-time measurement, it gives us a live refraction, it measures a phakic and the pseudophakic refraction and helps us measure to choose the IOL power and adjustment of the rotation if needed. But well, the results can be skewed with surface changes, OVD choice, the IOP maintained, etc. And again, it just guesstimates the ELP. It's not a foolproof method, but what I can state to sum all this up is that the future is here, and are we ready? And we should be ready. Thank you. So do I have questions here from the audience or from the co-instructors? Anything they would like to add upon?
Anything? Yeah, about the smartphone marking, I mean, most of them would be interested. I mean, you said that you have compared with the variant.
Yes, sir.
But then when you take that initial photo, do you go to, I mean, it's saved in the phone, and then you go back to the patient and again you mark it, or I mean, I was not very clear on that.
So, sir, when the smartphone marking is done, well, the patient is sitting upside, his head is straight, and the patient is looking eye to eye. That light is shown, and there should not be any tilting of the head. So we need to see whether the light is passing through both the pupil of the patient. So then we know that it is 0-180 degree. And then once we've taken the photograph, we know that this mark is not at 0-180 degree, it is at 2 degree. So in the OT, we just need to remember that this mark is at 2 degree, and we need to align the Mendes ring accordingly. We need to consider that 2 degree as 0-180 degree. Absolutely. So we need to apply that Mendes ring accordingly and just proceed with the surgery.
See, it's a basically gel-Devere algorithm. Basically, it is like eye trace. You just mark freehand in both the place, and you do the eye trace, and eye trace will show you it is how much degree difference from the 0-180 degree. That Shourab Patwardhan has that app is basically same, but you have to do this freehand manually, and very difficult to focus center part of the cornea. To be frank, I
That's what
tried a lot.
we
It's very
are
difficult,
trying to.
but if your hand is very steady, you can do it.
But you can move the circle and you can.
Yes,
what-
that mark you have to mark ink mark first and take a photograph, and that caliper you how much from the zero, and then you set that mark. Say that mark is 10 degree. Then you your axis marking with reference to that.
So probably will it be better if you do a bubble marking and then use the
Sir,
camera
I don't
rather
go for
than
bubble markers. I go for freehand marking or the variant marking, and in my experience, I've got very good results with freehand marking. Confirmed with this smartphone. And like for the people who, like for steadying your hands, what you can just do is, you can just put one finger on the forehead of the patient and then, stabilize the camera and take it.
Only 6 o'clock?
Pardon?
no 0180 side.
So we can mark anywhere, we need not even mark, we can consider any iris vessel or any scleral vessels for that, and just assume it to be the mark instead of manually marking
then
it.
you compare with the
Data with the variant.
Saurabh app.
Yes, then we
Okay,
just
yes,
take
that
that
I
mark,
think.
like if I'm
This
taking
is
this
the
scleral
same
vessel
principle-
and just...
Same principle we were using in the eye trace machine.
Correct.
Yes, but it is a very cheap, consistent, and for the beginners, it's a
But yes,
wonderful tool.
very
I would
difficult
suggest
to-
everyone to try that out.
So
To be
I
frank,
just
practically
thought,
it's very
can
difficult
it be
to get the
mounted on a
picture of, corneal photo.
some sort of where see the only problem is putting that hand steady and ask it. So can it be mounted on a slit lamp or some sort of device and ask the patient to
But so
look?
you have to take it really close, so you can't mount it
So
on a
you
device.
can just put one finger on the
Finger, I
forehead of the patient and stabilize the hand. So then that doesn't
So
work.
I think the best part is, like Dr. Swati said, that it is difficult. Even the toric cam, which is a little better than this one in terms of its taking pictures.
Right.
But how we started off, like Dr. Swati said, I will, if I don't have access to a variant on that day, I will do a manual marking and just use it in, let's say, 10, 15, 20 cases, so that you know that typically you are off by 2, 3, 4 degrees. Normally we have seen that even if you do just simple ink marks, 0, 180, you will be within 5 degrees on either side. So just do it in 15, 20 good eyes, myopic, or where you have good exposure, and find out what's your average deviation. So you don't need to do it for every eye, because that's too much of a stress, like sir said.
Right.
Quality of the mobile picture are not so good. So we need something better which can take better pictures. So blood vessels all are visible. So we can design some manual image guiding system because that type. And second thing I want to say that when we are predicting PCA, all the machines, there are some extrapolating, some measuring the anterior, the ACI, OCT and something. I think Cassini may be the best because it is taking anterior and posterior both at the same time. It is measuring the physiology. One being of the anterior
measured and predicted.
Other are extrapolated.
Predicted.
Predicted.
So for most...
Master is a predicted. But even anterior has a measured one. Now the machine has
So even with...
measured the corneal action.
So for most practical purposes, the measured PCA is equal to the predicted PCA. So we can all, for most practical purposes.
I have seen one study that I have on this, that and the, for anterior, Cassini and all are same, okay. And but for posterior, there are variation in the Cassini and this IOL master and all the Pentacam.
That actually there is a top of Dr. Sagar.
See, one
I
thing
would
is,
request
one
Dr.
thing I
Rajapal
just
to
wanted
get ready
add
with his
one
presentation,
point,
sir.
that if you have a with the rule, then you will have a consistent against the rule PCA. That is very clear. If you have a with the rule astigmatism, you don't worry too much about PCA. The problem happens if you have oblique and against the rule astigmatism. That's where the posterior corneal curvature can show variation.
Only in 10 to
Still,
15% cases.
still about 50 to 60% will have against the rule, but the quantum can vary. You know, the spread is from 0.2 to 1 diopter.
2 to 1 diopter.
You can have that.
Variation could be
So I think there is good news in that sense, because see, I mean, there are so many instruments, and you don't just buy an instrument for the posterior cornea. There are many factors you consider when you buy a topographer. But the good news is that when there is a study which showed Barrett universal formula with predicted posterior, that means what they normally do versus IOL master measured. In fact, the predicted was, if not a shade better, but not inferior. So I think for most 90% or 95% cases, we don't need to worry about measured PCA today at least. with the level of technology, not everybody is actually measuring.
Yeah.
So it's a lot of assumption in both sides.
And definitely you can invest in one can have a good smartphones. People are going for smartphone photography. So the quality of smartphones definitely is not much of a matter of concern. We can get scleral vessels through it and definitely go for ink marking, if not these scleral vessels. And so